συνέχεια, γιατί η ομιλία του καθηγητή κ. Irkec είναι αφοσιωμένη στο θέμα αν πραγματικά χρειαζόμαστε τα συντηρητικά στην αντιγλαυκοματική θεραπεία. Murat, it's a great pleasure to listen to you. Please.
Thank you, Tasso. I think after the panel, many things are quite clear enough, but this title of my talk is actually the title of my editorial I've been asked to write for the British Journal of Ophthalmology. And the question is, do we really need preservatives for efficacy of glaucoma medications? And I will try to do a critical approach for that. And as the prologue, we've heard that glaucoma is a multifactorial problem, and it is a progressive optic nerve damage and the loss of visual function. And in established open-angle glaucoma, lowering IOP is effective and is always advised. It is generally the first-line treatment we try to do in our clinical practice. And initial treatment for glaucoma typically involves lowering and subsequent control of IOP with pharmacological therapy. So the most common means to treat glaucoma is just putting the topical solutions into the conjunctival sac, and eye drops usually penetrate through the corneal or scleral route. This is something very important, especially the scleral route is very important in this respect, and there is some conjunctival contribution. Although well accepted by patients and their physicians, solutions might not be ideal in terms of bioavailability. Bioavailability is very important in drug efficacy. And in general, the glaucoma medications have a short contact time, and several factors are actually affecting their availability, like they might be washed out by the tear film, and there is limited capacity of the conjunctival cul-de-sac, and also the glaucoma medications will be diluted by tears and also by the aqueous humor, and there will be some drainage into the nasolacrimal duct. And furthermore, there is a very complex structure of the corneal epithelium, and it's a big barrier to hydrophilic, not to lipophilic, but to hydrophilic drugs. And when we look at the composition of glaucoma medications, there are several ingredients like the chemically active component, a vehicle for the drug, a preservative, some buffers, and other stabilizing molecules. All of those are very important, especially in low-quality generics. This is a big problem. And preservatives have to be included in all multi-dose eye drop bottles. What is the rationale for including preservatives in ophthalmic preparations? First of all, health regulatory agencies mandate that manufacturers of multi-dose topical ophthalmic medications should include preservatives. Preservatives inhibit the growth of microbial contaminants in the bottle, prolongs the shelf life by preventing biodegradation and therefore preserving the drug potency, and they allow for a convenient and safe multi-dose container for the patient use. Do they increase the corneal penetration of the drug? Not true for many prostaglandins and even for beta blockers. If the medication is an aqueous solution, it will be very difficult for it to penetrate. However, this is a very historical view. If in 1970s we were only relying on certain glaucoma medications, we had produced in our pharmacy-based, hospital-based pharmacies, and all of those were aqueous solutions. And for a simple aqueous solution to penetrate the cornea, it should be somewhat lipophilic, or either you should have some small openings in the epithelium or some breakdown of the cell-to-cell junctions. But this is not true for many molecules now, except pilocarpine. And actually, we have many preservatives, as mentioned before. We have the cationic surfactants like the benzalkonium, the classic benzalkonium since 1940s, and we have the polycationic, seemingly similar but actually different, the polyquaternium, since the middle of 1980s. especially used in contact lens care systems. And we have others. Mercurials disappeared. That was the worst of all of those preservatives, resulting in blinding keratopathy. So they are just abundant now. And we have some vanishing preservatives like the Sofcia in the United States, purite, and sodium perborate. Actually, when we look at the prevalence of ocular surface disease in patients with glaucoma, there are very good studies. This comes from Lung and published in Journal of Glaucoma in 2008. And almost 1/3 of glaucoma patients at the age of glaucoma suffer from some type of ocular surface problem. Or in broad terms, they may suffer from dry eye. And almost 2/3 have low Schirmer's values. And when we look at the corneal and conjunctival lissamine green staining, they have staining. And the tear breakdown is really short in those patients. Another study comes from Germany, from Karl Loeb's group, and the results from German Glaucoma and Dry Eye Register shows that the type of glaucoma is important, especially in the appearance of ocular surface problems. For example, in exfoliative glaucoma, which is a common problem within Greece and in Turkey, almost 50% of our glaucomas belong to this group, and persons are older and patients have much more exaggerated ocular surface problems. The condition is getting worse and worse, and the quantity of eye drops, especially when we use more than 3 medications separately, the problem is much worse in comparison with single medications or monotreatment. On the other hand, we have to be concerned about what's happening in relation with regard to the preservatives, the ocular surface. And it has been suggested that cytotoxic effects of preservatives are often under-recognized. This is true. We generally don't give our time to look at whether our patients suffering from a type of ocular surface problem. And ocular surface changes induced by preservatives lead to poor tolerance and to low compliance in those patients. One significant point is that many patients with preserved medications do not complain about stinging, because those medications, actually the preservative BAK, results in hypoesthesia, as we have shown that there is changes in the subbasal nerve plexi, especially in the cornea. And when we look at the benzalkonium, very simply in my cartoon, there is actually one hydrophilic pole which is important for microbial effects, and there is one hydrophobic pole which has the detergent properties, just conferring the detergent properties on benzalkonium. And what the detergent property result in is actually a soap effect. So cell membrane destruction, breaking the lipids, and in this cartoon I readily show that after breakdown of the surface lipid layer and the cell membrane, BAK goes into the cells, remains in the cells, and after the cell is dead, it comes out once again. So there is a perpetual contact of BAK with the surface epithelium, with both the conjunctival and corneal epithelia. And what is the end result? Actually, it is tear film instability plus the patient's ocular surface problems resulting in the same problem, and loss of the goblet cells, loss of mucin, especially the conjunctival mucin, and increased inflammatory response. This is one of our patients we studied with immunopathology, and this is a patient with almost no complaints, and we got the specimen just before the trabeculectomy or within the surgical session. And when we look at the conjunctiva, we can readily see that there are some cells expressing both in the epithelium and also within the stroma, showing interleukin-2, which is very important as the first step for inflammation. And just this is very important. There is an increased number of these elongated cells, the CD68 cells. which are actually the antigen-presenting cells in the conjunctiva. So what is happening is actually is not allergy, it is toxicity, and even toxicity is much more important in comparison with the allergic response. And another thing I will show is the expression of HLDR. HLA-DR is the, one of the best indicators of markers of inflammation. And this is another study, and we can, when we look at our study, with one medication, there is grade 1 HLA-DR expression. However, when the patient is on 2 medications, there is much more exaggerated HLA-DR overexpression, and it is showing that there is inflammation. And with grade 3 epithelial overexpression, especially the patient is using more than 2 medications. This is readily evident, and this is another study of ours going back to many years, and we have shown that the conjunctival epithelium, subepithelium of the patients are populated with inflammatory cells, and also there is apoptosis of the conjunctiva. So these are all results of the preservatives, not the medication, not the compound, active compound by itself. And this is something from the real life. This is a patient of ours, failed trabeculectomy. Within the first postoperative month, we can readily see that there is an elevation of the intraocular pressure, and in the second postoperative month, the failure is more evident, and the IOP is going up higher. And when we did the confocal microscopy, we can readily see that those vesicles, which should be bigger, is less in number, and also there is accumulation of the new connective tissue, and also vascularization of the bleb area, which is a very bad sign for the fate of trabeculectomy in those patients. And this is a slide I borrowed from my friend Christophe Baudouin, and this belongs to many years ago. When we did our practice in 1970s, we had those cases of pseudopemphigoid, actually. Nowadays, still I think if we get some biopsies, we can see some of those pathologic changes in some of our patients. So do we really need preservative in ophthalmic solutions? And actually, pilocarpine, prednisolone, and some beta blockers needed in aqueous solutions, BAK. However, it could be claimed that this effect is desirable since there will be more permeation of the drug and there might be a more intense pharmacological effect. However, another thing we have to think about is that many modern topical medications do not necessitate damaging effects on the corneal epithelium in order to achieve potency at the target tissues. And the use of preservative-free single-dose units is a solution to avoid the preservatives and adverse effects associated with their use. Do we have real scientific evidence for that? Yes, we do have. And this is a study with unpreserved timolol maleate, and it is a non-inferiority study. A non-preserved T-gel, carbomare plus timolol was very safe, almost very similar, and this overall study result showed us that T-gel is not inferior to T-gel preserved. On the other hand, we have similar results from the fixed combinations, preservative-free fixed combinations, and this is also a good study, data from a prospective open study almost covering more than 2,000 patients, and this observational study also confirmed that IOP lowering effect of preservative-free eye drops is almost very similar to what is in multi-dose bottles. Prostaglandin analogs and preservatives. Prostaglandins are our choice most of the time as the first line. They have superb efficacy and they have a very good safety profile. And prostaglandin analogs with BAK may exert cytotoxic effect on the ocular surface, like latanoprost. The classic latanoprost has the highest concentration of preservatives. And in this respect, we have some other evidence that prostaglandin analogs without preservatives are doing very good. Bimatoprost may be an exception. However, bimatoprost has been shown to reach the target tissues, favoring the conjunctival scleral absorption route. So in this respect, bimatoprost acid may have only a limited contribution and does not necessitate a BAK inclusion into the solution. On the other hand, what we have to keep in mind is that prostaglandins are prodrugs. And for a prodrug is lipophilic, more lipophilic, so it can just permeate into the conjunctiva, into the corneal, and therefore it does not need any preservative. The unidose does not need any preservative for efficacy. This is another study for preservative-free latanoprost, and almost the same results, and there is the indirect comparison, and preservative-free latanoprost is non-inferior. It is quite effective in comparison with its preserved form. Bimatoprost preservative-free also shows us almost the same results, and preservative-free bimatoprost is also very efficacious in this respect. And this is the study by another group showing that the tafloprost preserved is a relatively new prostaglandin analog, and it's a prodrug, very similar to other prostaglandins. Maybe bimatoprost can be an exception. And tafloprost has been shown to be non-inferior to glaucoma drops, including beta blockers and other prostaglandin analogs. And its improved adverse effect profile makes it a viable alternative in patients with preservative-associated ocular surface disease, like the redness and also maybe the inflammation. A recent study, which our editorial is written because of that study, and this is the study coming from Professor Constant's group, a multicentral study, and a 24-hour IOP control obtained with a preservative-free tafloprost, and is compared to branded BAK preserved latanoprost. And in this prospective crossover study, this is very important because it's a crossover study. Crossover studies are very important in the comparison of the medications, and the authors demonstrated very clearly that preservative-free tafloprost achieved similar 24-hour intraocular pressure reduction to branded latanoprost. So to make a long story short, preservatives are not necessary to improve the efficacy of unidose glaucoma drops, including the beta blockers, carbonic anhydrase inhibitors, and various prostaglandin analogs. And several studies have put into question the notion, the old telltale, that preservatives in glaucoma medications enhance drug penetration, since preserved and unpreserved glaucoma drops have similar efficacy. In current practice, glaucoma patients, particularly those with ocular surface disease, are fortunate to have efficacious but safer alternatives. At least going back to the discussion with Temis, I have to say that we can also have a safer alternative. It is going to be preserved, like Poluquat, which is time-tested. However, I'm of the opinion that with unidoses, it is very, very, I should say, unnecessary and superstitious, in my belief, to have a BAK in our glaucoma medications. Thank you very much for your attention.
Thank you, Murat. Θα συνεχίσουμε με την ομιλία του Νίκ Στρουθίδη, που πραγματικά έχει ένα θέμα που είναι από τα πιο γοητευτικά στην έρευνα του γλαυκόματος, imaging of the lamina cribrosa. One of the most exciting topics in ophthalmic research, Nick. The last time I didn't catch everything. I hope I will be able to get everything this time around.
Kalimera. I need to connect up. This is called maculopathy because of... Does the kit come on automatically or not?
I don't know. Can I say something?
Yeah.